Hello everyone, I am Dr. Dhanya. In today's session, I am going to deal with early pregnancy bleeding, its assessment and investigations. The management part I will discuss in next class. This class is purely based on Australian guidelines because we are focusing on AMC exams. So without much delay, let's start our session. In Australia, about 20 to 40% of pregnant women will experience bleeding during the first trimester of their pregnancy. It is a very distressing symptom, and usually they present to the general practitioners first. But in most of the cases, we can't make a proper or correct diagnosis during the first presentation itself, and we sometimes need a follow-up investigation, or sometimes we need to refer them to the specialist. So a proper management or a proper assessment is important for the early pregnancy bleeding, and this topic is very important for your AMC exams also. Without a proper management or assessment, this can lead to life-threatening consequences also. So this topic is very important. So what are the causes of early pregnancy bleeding? The major causes in Australia: miscarriage about 10 to 20%, ectopic pregnancy 1 to 2%. If the patient came in their very early stage of pregnancy, it may be due to endometrial implantation itself. So the rare causes are cervical and vaginal lesions like malignancy, cervical ectropion, polyps infection, uterine infections, and gestational trophoblastic diseases. So when a patient comes with early pregnancy bleeding, and if her beta CG value is abnormally high and the USG showing a snowstorm like appearance, then you should think of gestational trophoblastic disease in that case. So this is a flowchart showing initial assessment of a patient with early pregnancy bleeding. So when a patient came with early pregnancy bleeding in less than 20 weeks of gestation and with or without abdominal pain or shoulder tip pain, you must first consider her hemodynamic stability. If the patient is stable, then you can go with detailed assessment, and if the patient is not stable, you must resuscitate the patient. If you are working in a GP setup, immediately refer the patient to the emergency department after establishing the IV access with 16 gauge cannula on both sides. The most likely diagnosis of hemodynamically unstable patient with early pregnancy bleeding are ruptured ectopic and incomplete miscarriage with cervical shock, or massive hemorrhage secondary to miscarriage. So in the emergency department, after initial resuscitative measures, you should do a speculum examination and look for any retained products are there at the cervical os. Why? Because in cases of incomplete abortion, the retained products sometimes may stuck at the cervical os, and that may lead to irritation of the parasympathetic nerve fibers that supplying the cervix, and can lead to the hypotension and bradycardia and cervical shock. So in order to prevent that, we should remove the retained products if you see them on speculum examination. So removing the retained products will help in reducing the bleeding and thereby improving the patient's blood pressure. And you should always catheterize the patient with indwelling catheter to empty the bladder. And you should always do an ultrasound, bedside ultrasound, to check whether there is any hemoperitoneum or if you are suspecting hemoperitoneum. And the shoulder tip pain is a symptom that can occur during the hemoperitoneum, and you should always consider an urgent gynecological review concurrently during the resuscitation process. And the other investigations you must do in emergency are uh, complete blood count and blood grouping, RH typing, and cross matching. And sometimes we need massive blood transfusions also. And in some cases, we need beta HCG levels also. If medically unsafe, do not delay the treatment for a formal ultrasound examination. And if you are suspecting is ectopic or ectopic is confirmed, then we need to continue the resuscitation procedure en route to the theatre. And if the patient is still bleeding and ectopic is excluded, then we can consider pharmacotherapy for stopping the bleeding. And what all surgical interventions are there? So, when considering the surgical intervention, we usually do suction and evacuation for the removal of retained products in case of incomplete early pregnancy loss, and laparotomy or laparoscopy for ectopic pregnancy. So that's it about the resuscitation procedure if the patient is unstable. So if the patient is hemodynamically stable, you can go with the detailed assessment starting from the history taking. In history taking, you should always focus on her menstrual history and her last menstrual period, and ask about her previous pregnancies, especially any history of miscarriage was there or any history of ectopic was there, and ask for her pregnancy outcomes also, and check for any significant gynecological history was there, like any history of pelvic infections in the past or any sexually transmitted infections in the past, or any history of tubal surgeries or usage of intrauterine devices or any mini pill usage, and ask about her cervical smear history also, but it is relevant if any abnormal bleeding outside her pregnancy was there in the past. Also, you should focus on the medical history, like any uncontrolled blood sugar levels was there or any thyroid disorders was there. So all these things you should keep in mind while asking the history, because all these can lead to ectopic or miscarriages. In present pregnancy, you can ask for the method of conception, any assisted reproductive techniques are used or not, and any other relevant ultrasound findings are there, or any quantitative beta HCG levels are there or not, and the symptoms of early pregnancy also can be asked. And you should always ask for the signs and other signs and symptoms, like the amount of vaginal bleeding, the extent or severity of vaginal bleeding, any associated pain like abdominal cramping or backache are there, and any postural syncopal attack was there, and any history of vomiting, shoulder tip pain or diaphragmatic pain, and any signs of shock is there, and any passage of products of conception is there. So all these things should be asked. If the patient is not knowing that she is pregnant, then the next step is confirming the pregnancy. So for confirming pregnancy, urine pregnancy test or serum beta HCG level can be done. If we are suspecting any delay in reporting, we should always prefer urine pregnancy test in a situation like early pregnancy bleeding. After that, we can do serum beta HCG if that is indicated. So always remember, when a patient in her reproductive age group came with complaints of vaginal bleeding, always suspect pregnancy irrespective of her last menstrual period or history of contraception or history of sterilization or history of any reported sexual inactivity. So always do pregnancy test for confirming a pregnancy in such situations when you are suspecting early pregnancy loss. Now about physical examination. So after baseline observation like temperature, pulse rate, BP, etc., we should do a thorough abdominal examination and look for the tenderness, rigidity or guarding, and look for distension of abdomen, and look for the vaginal blood loss, the amount and the severity of blood loss. And during speculum examination, as we have already discussed, if any return products are there, you should remove the products and check for any other source of bleeding is there, and do a bimanual examination and check for any cervical motion tenderness is there, and the state of cervical os, and assess for any adnexal masses are there, and the size of uterus is assessed. So after physical examination, we do ultrasound examination, in which transvaginal ultrasound is preferred in the early pregnancy. And in my previous session, I have discussed one MCQ from this topic. So if you can recollect that question, in that question they have mentioned about in detail about the menstrual history and the symptoms, and then they given the examination findings there, and then asked for the next step in the management. So in the similar way, here also we start our assessment from history taking, then the examination, then if the patient is not pregnant, confirm the pregnancy, or if the patient is pregnant, we should follow the assessment with transvaginal ultrasound. So the other investigations that we can do are the complete blood count and blood grouping, RH typing, and if there is severe bleeding, we can do serum electrolyte level and her renal status, renal function status, like serum creatinine, urea. And if the patient is RH negative and her husband is RH positive, ask for her previous obstetric history and check her immunization status. Do an antibody screening if there is history of recurrent miscarriages. If the patient is more than 25 years of age and she is in high risk group, we can do sexually transmitted infection screening also for chlamydia infection or Neisseria infections. Usually we are preferring high vaginal swab for the examination, and in case of chlamydia we can also use urine NAT test also. And in cases of early pregnancy losses, we should always do blood sugar monitoring of the patient and the thyroid status of the patient to rule out uncontrolled diabetes or thyroid disorders. The next step is confirming the pregnancy location. So there are three possibilities. One is intrauterine pregnancy, the second one is ectopic pregnancy, and the third one is unknown location. So if the pregnancy is of unknown location, we need to refer the patient to specialist and need a review with serial beta SAG or serial TVS assessment. So this is the approach to a patient with early pregnancy bleeding. Now we can discuss about approach to a patient with early pregnancy bleeding using ultrasound examination. If a patient is pregnant and with a positive urine test and positive serum beta SAG level, and the patient is presenting with pervaginal bleeding with or without abdominal pain, we should always do an ultrasound examination. So in ultrasound examination, you should check for the intrauterine gestational sac. If the gestational sac is present, you should check for the fetal pole. If the fetal pole is seen, you should check for the fetal heart rate. If the heart rate is present, then probably it is a viable intrauterine pregnancy. So we can diagnose this as threatened miscarriage. If the fetal pole is seen and there is no fetal heart rate, then you should check for the crown rump length. If the crown rump length is more than 7 millimeter, then probably it is a miscarriage. Then we should ask the patient to review after 7 to 10 days for confirming the diagnosis. If there is no fetal heart rate but the CRL is less than 7 millimeter, then probably it may be a wrong date or pregnancy following delayed ovulation. So we should ask the patient to review after 7 to 10 days for assessing the viability of pregnancy. Then if there is intrauterine gestational sac but there is no fetal pole, then we should assess the gestational sac diameter, and if the sac diameter is more than 25 millimeter, then probably it is a miscarriage. In a similar way, we ask the patient to review after 7 to 10 days for confirming the diagnosis. And if the sac diameter is less, that means less than 25 millimeter, then probably it is a wrong date or an early pregnancy. Then we should ask the patient to come for review after 7 to 10 days for confirming the viability. If there is no gestational sac, you should look for extrauterine gestational sac or adnexal masses. If that is present, diagnosed as ectopic, then manage it as ectopic pregnancy. Suppose if there is no intrauterine or extrauterine gestational sac, then ask for her previous USG findings and ask for any history of products of conception was there in her previous visit or an examination. If she is giving history of products of conception or gestational sac in her previous visit and now it is not there, then it is diagnosed as complete miscarriage. If there is no intrauterine or extrauterine gestational sac and the products of conception is seen in transvaginal ultrasound, then it is diagnosed as incomplete miscarriage. Suppose if there is no gestational sac on ultrasound and products of conception on local examination, but her pregnancy test is positive, then it is considered as pregnancy of unknown location. This is an ultrasound showing an early intrauterine gestational sac. This is the uterus. This is the endometrium, means the decidua. This is the gestational sac. This is the image, ultrasound image showing ectopic pregnancy. This is the uterus. This is the ectopic pregnancy. This is the left ovary here. So when there is pregnancy of unknown location, then repeat the serum beta HCG after 48 hours. So in case of pregnancy of unknown location, we need serial beta HCG level after 48 hours. If the serum beta HCG level rising more than 63% after 48 hours, then probably it is an intrauterine pregnancy. But in 21% of cases, there is a chance of ectopic pregnancy also. So we should repeat the transvaginal ultrasound in 7 to 10 days or earlier if the beta hCG level is more than 1500 international unit per ml. What is 1500 international unit? It is known as discriminatory zone. Why? After this level only we can see the gestational sac in transvaginal ultrasound. So there are possibilities like viable intrauterine pregnancy or missed miscarriage or ectopic pregnancy or pregnancy of unknown location during the follow-up. If the serum beta hCG level is falling less than 50% or the rise is less than 63%, then there is high risk of ectopic pregnancy. So you should refer the patient to a specialist for further assessment. If the beta hCG level fall more than 50%, there is a chance of non-viable pregnancy. So ask the woman to do a urine pregnancy test after 2 weeks. But ask the patient to report to the care provider if patient is having worsening symptoms or new symptoms or urine pregnancy become positive. If the pregnancy test is negative after 2 weeks and the patient's symptoms are resolving, then it can be considered as no longer pregnant but location not determined. So that's it for today. In next session, I will discuss about the management part, in which I will cover the miscarriage management and ectopic pregnancy management. So thank you for watching.